afternoon, everyone. I would like to welcome you to this afternoon's webinar, which is entitled Out2Enroll, the Affordable Care Act and LGBT Communities. Before I begin, I'd like to make sure that the audio portion is working. If you can hear me, can you click on the little hand icon to indicate that you are able to access the audio? Great, thank you for confirming. If you are calling in by phone, make sure that you did enter the audio pin that was provided. Otherwise, if you would like to ask a question later on during the Q&A portion, you wouldn't have the audio to be able to speak. Otherwise, if you're listening in via your computer, it likely will show a microphone icon that's next to your name, versus if you're calling in, there should be a telephone icon next to your name. Great, thank you, everyone. And also, throughout the webinar, feel free to submit any questions that you have, because when we get to the Q&A session, I will review the questions and we will try to answer as many as possible. So to move on, a few general housekeeping rules. If you do experience any technical difficulties during today's webinar, please contact GoToMeeting.com's corporate account customer support at the numbers listed below. I'll give you a few seconds to jot those numbers down. And that way, if you do encounter any difficulties, you will still be able to access the webinar. I also do realize that some people are joining us only via the audio. If you want to make sure that you can see the slides, you'll want to make sure that you clicked on the link in the confirmation email that you received. GoToMeeting will download onto your computer, and then you will be able to view the slides. Also, today's webinar is being recorded, and both the webinar recording and the presentation slides will be available within 24 hours of today's webinar. In addition, at the conclusion of today's webinar, you will receive an evaluation so we can assess how we are doing, and we would really appreciate the feedback. So moving on, let me tell you a little bit about our center. The Hopkins Center for Health Disparity Solutions was founded in 2002 by our center director, Dr. Thomas Levis. We are a research unit in the Department of Health Policy and Management in the Johns Hopkins Bloomberg School of Public Health. Our center is funded by the National Institutes of Health, the National Institute on Minority Health and Health Disparities, and we have been designated a National Center of Excellence in Health Disparities Research. In these very challenging economic times, we are very pleased that during fall 2012, our center received its third 5-year grant cycle of funding. In addition, we are particularly proud of Dr. Levis because at the end of October, he was inducted into the Institute of Medicine of the National Academy of Sciences. So congratulations to our director, Dr. Thomas Levis. And at this time, I would like to turn the presentation over to our presenter, Kellan Baker.
Thanks so much, Cherie, and thanks to all of you for joining us this afternoon to talk about the Affordable Care Act, something that has been in the news quite a lot recently, and LGBT communities. This webinar is on the basis of work that's being done here at the Center for American Progress in Washington, D.C. We are supported in part by the Sellers Dorsey Foundation, which is a private foundation in Philadelphia, and you will be hearing more about the initiative Out2Enroll, which is a joint effort between the Center for American Progress, the Sellers Dorsey Foundation, and the Federal Agencies Project. If we can go to the next slide. Thank you. So just before we start talking about how the Affordable Care Act will affect LGBT community members, I want to take a step back and talk a little bit about who LGBT individuals are. What do we mean when we're talking about the LGBT community? According to recent research from the Williams Institute at the UCLA School of Law, approximately 8 million Americans identify as gay, lesbian, or bisexual. Another 700,000 are estimated to identify as transgender, which gives us the number, a very conservative estimate, of at least 9 million LGBT people. And I say that's a conservative estimate because we know that there are many people who do not choose to identify with the political categories, which is really what they have become in so much of the modern discussion about sexual orientation and gender identity. People do not necessarily identify with labels such as gay, lesbian, bisexual, or transgender. So again, this is probably a very significant undercount of how many people we're actually talking about when we're talking about people who are experiencing health disparities, healthcare access disparities on the basis of sexual orientation or gender identity. Go into the next slide. Thank you. And just to help us fix in our minds who we're talking about, when we mean 9 million LGBT Americans, that is roughly the size of the population of New Jersey. So this is a sizable community that we're talking about here when we're trying to figure out how do we make systems work better for people who identify as lesbian, gay, bisexual, or transgender, or who experience difficulties getting the healthcare coverage and healthcare that they need because of their sexual orientation or their gender identity. I'll just do a little bit of a pause so that when we go to the next slide, thank you. Looking at some examples of LGBT health disparities, when we say that LGBT people frequently have trouble getting the health care that they need, what impacts does that have on their day-to-day lives? Some of the health disparities that have been documented by sources such as the Institute of Medicine and Healthy People 2020 include elevated rates of tobacco and other substance use, mental health concerns such as depression, cancers, experiences of violence and abuse, which is unfortunately a very real reality for many members of the LGBT community, elevated rates of HIV and AIDS infection, and with regard to healthcare access disparities, lower rates of insurance coverage in many cases. According to the Institute of Medicine, people in same-sex relationships are roughly twice as likely as their heterosexual counterparts to have difficulty getting adequate insurance coverage. When you look at the experiences of LGBT individuals, as we will do later on in this presentation, we see elevated rates across the board of uninsurance for LGBT. Is access to insurance coverage. So when you're not able to get insurance coverage, there's frequently obstruction to getting, for example, the preventive screenings that people need to make sure that they are able to stay healthy and to catch some of these conditions such as cancer before they become dangerous. Next slide. Thanks. Fortunately, there are numerous tools in our toolkit just over the last couple of years. There has been what I would call an explosion, really, of national efforts to address LGBT healthcare disparities and LGBT health status disparities. Some of these include Healthy People 2020, which was released in 2010. For those who are not familiar with Healthy People, the federal government's blueprint for a healthier nation in every decade. The Healthy People 2020 plan that was, again, put out in 2010 and is intended to take us through 2020 is the first Healthy People plan to include a topic area specifically focusing on LGBT health. The National HIV/AIDS Strategy, which also looks at the drivers of the HIV epidemic, which continues to disproportionately affect gay and bisexual men in particular, as well as transgender women, and particularly gay and bisexual men and transgender women of color. The National HIV/AIDS Strategy looks at the drivers of this epidemic as including sexual orientation and gender identity in as much as they are related to societal stigma, to discrimination that people are experiencing on the street when trying to get a job, when trying to get health care, and looking at the ways that any effective response to the epidemic needs to include a focus on those aspects of people's lives, such as sexual orientation and gender identity. The Institute of Medicine report on LGBT health, I call it the Bible, released in March of 2011. It was an effort to look at the state of the science around LGBT health, and so it is a very clear picture of, while we know quite a bit about the experiences that LGBT people have and some of the challenges that they face in trying to stay healthy, there is much that needs to be learned, more research that needs to happen to help pin down what are these disparities and, more importantly, what are effective ways of addressing them. The National Partnership for Action to Eliminate Health Disparities, one of the leaders in addressing LGBT health concerns at the national level, has been the Office of Minority Health, under the leadership formerly of Dr. Garth Graham and now under the leadership of Dr. Nadine Gracia, really looking at all of the factors that make up a person's identity and understanding the ways in which disparities affecting people on the basis of race, for example, it's not possible to fully address those disparities in a vacuum, not looking at the role that's played by factors such as LGBT identity. The National LGBT Health Education Center at Fenway, which is the large LGBT serving community health center in Boston. They have a training and technical assistance center that works to help community health centers serve LGBT patients. The National Healthcare Disparities Reports and the Culturally and Linguistically Appropriate Services Standards. These are both from the U.S. Department of Health and Human Services, and again, looking at the ways that LGBT disparities intersect with and in many cases magnify disparities that people experience on the basis of, for example, race, ethnicity, or disability status. And of course, I would be remiss if I didn't note that the biggest tool, I would argue, in our toolkit for actually addressing LGBT health disparities is the Affordable Care Act itself. This is U.S. My apologies. This is Secretary of Health and Human Services, Kathleen Sebelius. The photo is actually her speaking at a recent White House event about LGBT communities and the Affordable Care Act. But the quotation from 2011, when she was speaking at the meeting of the National Coalition for LGBT Health about why the department views the Affordable Care Act as important for addressing the concerns of all Americans, including LGBT people, she stated, "The Affordable Care Act may represent the strongest foundation we have ever created to begin closing LGBT health disparities." And the key word in this for me is may, because nothing is for certain with regard to how the law will affect our communities. And it will take everyone pulling together to make sure that the law is implemented in a manner that actually addresses the concerns that various communities are experiencing and that actually effectively engages LGBT community members in making sure that ourselves, our families, and our communities are healthy. So looking at what are some of these efforts that are underway, what are some of the opportunities in the Affordable Care Act, my friend here, shirtless Ryan Gosling, is going to help us walk through what some of the top priorities for using the Affordable Care Act to address LGBT disparities. Number one on my list is new options for coverage. As we know, more than 50 million people in this country do not have health insurance coverage. That is one of the major drivers of some of the poor rates of health that we see in our country. The Affordable Care Act is an attempt to address that problem of people lacking access to coverage and then, in too many cases, lacking access to care. So this is something that I'm sure many of you are familiar with already, some of what's in the Affordable Care Act itself. So I hope you will bear with me as I tease out what are some of the ways that these particular provisions of the law have particular relevance for LGBT communities. So looking first here at the new options for coverage, lowest income people, the Medicaid expansion, as we know, in participating states only. Most people, middle income people, the health insurance marketplaces, and small businesses, the small business marketplaces, which I won't be talking too much about today, but I will be happy to take questions about the small business marketplaces if that's something folks are working on. Next slide. So looking at the Medicaid expansion, which is, again, one of the ways that the Affordable Care Act envisioned expanding access to people with a range of incomes, the really key piece of the Medicaid expansion for LGBT community members is that it opens access to the program for many LGBT people for the first time. And the reason that that is the case is, as we know, prior to the Affordable Care Act, the states were able to decide what the income ceiling was over which people were not able to get access to coverage through Medicaid, and because of the categorical eligibility categories. That was redundant. Categorical eligibility being defined as people who have a disability, for example, or pregnant women, and in many cases left out single childless adults, which includes many members of LGBT population. Under the Affordable Care Act in those states that are accepting the expansion, everyone making up to approximately $16,000 a year is eligible for coverage. So again, that will include many LGBT people, particularly those who are childless for the first time. It also, in expansion states, the law has removed the requirement that people living with HIV have to be disabled by an AIDS diagnosis before they can qualify for Medicaid coverage. Looking at how the Medicaid programs will treat same-sex spouses, according to guidance that was recently issued actually earlier this fall, these states have latitude to determine for themselves whether or not they treat same-sex spouses as married for purposes of determining Medicaid eligibility. And this is a peculiar situation that is brought on by the mixing of federal and state dollars in the financing of the Medicaid program. The decision by the Supreme Court earlier this year regarding the Defense of Marriage Act, which formally prohibited the federal government from recognizing same-sex marriage. Under that decision, the federal government will allow now states to treat same-sex spouses as married for purposes of Medicaid eligibility, but again does not require them to. And it's not clear, for the most part, looking at where the different states are, it's not clear what number will actually take the step of deciding that same-sex spouses are married for purposes of Medicaid eligibility. Some of the current questions that we're still left with, in addition to which states are treating same-sex spouses as married, are which states are expanding, what benefits are actually covered, since we know that the benefits that are available for the Medicaid expansion population are different from those that are available for people on traditional Medicaid. So how can we, for example, make sure that transgender people who are newly eligible for Medicaid coverage are able to get the care that they need without encountering transgender-specific exclusions in state Medicaid programs? And what additional rules govern access? So again, bringing us back to questions, for example, of the definition of marriage varying from state to state. Next slide. Next slide. And of course, the other piece of the coverage expansion, the health insurance marketplaces. You can see there the logos for all of the 17 states that are running their own marketplaces, as well as the federal health insurance marketplace that is operating in the remainder of the states. As we know, the health insurance marketplaces ideally, or optimally at least, would have all opened flawlessly on October 1st, 2013. It's been a bumpy ride so far. That said, there are marketplaces that are operating in all of the states, and the marketplaces are really a key aspect of why the Affordable Care Act is such an enormous opportunity for addressing LGBT health disparities and healthcare access disparities, because the regulations from the federal government implementing the marketplaces, both in states that are running their own and in states where the federal government is running the marketplaces, these have LGBT inclusive non-discrimination requirements covering marketplace staff, the qualified health plans, and the navigators and all other consumer assistance personnel. So what we have here is a situation in which, in many states, this is the first time that there has been a law on the books, regulations on the books that require non-discrimination on the basis of sexual orientation and gender identity. So this is a huge opportunity to establish good practices in the health insurance industry through the marketplaces that will help ensure that LGBT people are able to get the coverage that they need without encountering barriers on the basis of their sexual orientation or gender identity. Next slide. Next slide. Number 2 on my sort of top 3 hits list is the insurance market reforms. So as we know, one of the primary things that the Affordable Care Act is doing in terms of reforming the healthcare system is eliminating some of the most harmful practices in the insurance industry that have meant that in too many occasions people have coverage that does not work for them, so-called Swiss cheese coverage that's full of holes. The Affordable Care Act institutes a variety of fixes for some of these worst practices in the insurance market. For example, the Patient's Bill of Rights, which lays out several innovations or several reforms that will make sure that coverage is more reliable. Some of these are particularly important for transgender people, for people with conditions that can be expensive and difficult to manage, such as HIV or cancer. The Affordable Care Act prohibits lifetime and annual limits on coverage. It prohibits the use of pre-existing condition exclusions, and it prohibits the arbitrary withdrawal of insurance coverage. Next slide. Next slide. And one of the biggest pieces of the insurance market reforms is the establishment of the Essential Health Benefits Standard. So the Essential Benefits Standard requires adequate coverage across these 10 categories of care. And importantly, as we saw with the regulations governing the qualified health plans and the marketplaces, plans offering the essential benefits may not discriminate on the basis of gender identity, health condition, diagnosis, etc. And this is going to affect plans that will be purchased by an estimated 68 million people nationwide. And I'm going to go into a little bit more detail about what the Essential Benefits Standard means with regard to an example of some of the worst discrimination that members of LGBT communities face when trying to get insurance coverage. Next slide. And so here we are setting up the discussion or the sort of case study investigation, if you will, of how the essential benefits standards are helping to drive better practices in the market for LGBT people. So looking at the non-discrimination requirements in the Affordable Care Act, the Affordable Care Act itself contains Section 1557, which incorporates the protections of existing federal civil rights law and extends them to any program or entity receiving federal money, which is pretty much everybody. These protections include the Civil Rights Act, which protects from discrimination on the basis of race, color, or national origin. The Rehabilitation Act, which provides protections on the basis of disability, which also includes HIV/AIDS status. The Age Discrimination Act, and Title IX. And importantly, in April of 2012, the Equal Employment Opportunity Commission ruled that the sex protections in Title VII of the Civil Rights Act, the employment protections, those sex protections include gender identity and sex stereotyping. So they protect actually transgender people from discrimination in employment. And the U.S. Department of Health and Human Services followed suit later in 2012, indicating that the sex protections in Title IX that are incorporated into the protections of 1557 actually do include gender identity and sex stereotyping as well. Next slide. So this has set up an entire new architecture of protections from discrimination on the basis of sexual orientation and gender identity, as well as other factors such as disability, race, or ethnicity. Looking at how these protections work together, I tend to look at them as a pyramid, with the Section 1557 protections, the broadest, those that apply nationwide, on the bottom. Moving up, looking at the regulations governing the essential health benefits, which I mentioned earlier, include protections from discrimination on the basis of gender identity, sexual orientation, disability, diagnosis, health condition, etc. Then looking at the regulations governing the marketplaces and the qualified health plans, which again include these the full slate of non-discrimination protections, and then looking at the applicability of state law and the ways that many non-discrimination protections in existing state law are actually being revisited and reinvigorated by the discussions around non-discrimination that are happening under the Affordable Care Act. Go to the next slide. Next slide. So this is the case study that I wanted to dive into in a little bit more depth. looking at the LGBT population, we see that there are two segments of the population that experiences particular difficulty when trying to access appropriate insurance coverage. And those two groups are people in same-sex relationships and transgender people. Many transgender people need healthcare services such as hormone therapy to express who they know they are on the inside. The American Medical Association recommends that transition-related care, care related to gender transition that may include mental health services, hormone therapy, and various surgeries. The AMA recommends that those services be available through insurance plans and that they are covered as medically necessary care. Unfortunately, what we see in the insurance market today is that the majority of plans that are sold in the individual market, the small group, large group, pretty much anywhere you look, these plans have transgender-specific exclusions that have some variation on the theme of if you are transgender, you cannot get coverage for anything related to your gender identity, related to being transgender. And while sometimes these exclusions are interpreted narrowly to mean, for example, no access to hormone therapy, we know that actually in practice, the exclusions are frequently interpreted very broadly to apply to any kind of care that a transgender person may need, such as treatment for pneumonia, such as a broken bone, such as preventive screening, such as a mammogram. And these are all stories actually from the field. The legal services organizations that work with transgender community members have documented exhaustive lists, cases in which transgender people are denied coverage for a variety of healthcare services, including those related to transition and those unrelated to transition. So looking at the implementation of the Affordable Care Act, state and federal regulators are in the process of deciding whether plans should be allowed to use transgender-specific exclusions under these various non-discrimination protections that we have just talked through. So looking at, for example, state unfair trade practices laws that prohibit sex discrimination, with the understanding of sex that includes gender identity, these laws are being revisited in an attempt to understand among state regulators in particular how their existing state laws should be regulating discrimination against transgender people in insurance. Similarly, state human rights laws, and those three big pieces of nationwide law that we saw coming directly from the Affordable Care Act, Section 1557, the Essential Health Benefits Regulations, and the Qualified Health Plan Regulations. Next slide. Next slide, thank you. So over just the last year, 5 jurisdictions have taken action to reject transgender insurance exclusions on the understanding that they violate gender identity non-discrimination protections in state and federal law. Those jurisdictions are Oregon, California, Colorado, DC, and Vermont. So this is a really excellent example of the ways in which the Affordable Care Act in a lot of ways represents a sea change in our understanding of how non-discrimination should function in insurance markets. Because we know that one of the ways that insurance works is by discriminating, by deciding who is of a particular risk and pricing products accordingly. But the Affordable Care Act is increasingly driving this discussion of there is discrimination that is merely differentiating between 2 different options, for example. But the kind of discrimination that many, for example, transgender people are experiencing is actually not rational at all and should not have a place in a reformed health care system or in insurance markets post-healthcare reform. Next slide. Next slide. So again, looking at the LGBT population and talking through the experiences of 2 groups that experience the highest obstacles to getting appropriate health care and health insurance coverage. Again, transgender people, but also same-sex couples. As we mentioned with regard to Medicaid, the Defensive Marriage Act decision at the Supreme Court this summer has a lot of implications, not all of which are fully worked out, for how different pieces of state and federal governments will treat same-sex couples. The one piece that we can be sure of, particularly in the healthcare context, is the DOMA decision makes it possible for same-sex spouses to apply jointly for the subsidies that are available to help make coverage affordable through the marketplaces. Prior to the decision, because same-sex couples could not file their federal taxes jointly, they were still able to get, or hypothetically, since the marketplaces were not yet open, but they would have been able to get the subsidies, but they would have had to apply for them individually. Now, again, after the Defensive Marriage Act decision, those same-sex spouses, regardless of where they live, are able to apply jointly. So if someone is married in New York, legally married in New York, and they move to, for example, Arizona, they are still able to apply through the Arizona marketplace for those subsidies as a couple. With regard to domestic partners and people in civil unions, unfortunately, the decision does not extend to the point where people who are in a domestic partnership or a civil union will be able to file their federal taxes jointly, and that means that they must continue to apply for subsidies through the marketplaces individually. Looking at some of the ways that marketplaces are coming up with to make sure that they are treating same-sex couples like heterosexual couples, allowing the use of tax credits to buy family plans. The Affordable Care Act does not include a definition of family and for purposes of purchasing insurance. So the Department of Health and Human Services has left that question open, delegated it to the states to decide whether the plans that are offered through the marketplace must offer family coverage, and if they do offer family coverage, whether that is open to same-sex couples. Keeping couples' records together in marketplace IT systems, this is particularly important for individuals who intend to use their tax credits to buy a joint plan, but who, for whatever reason, because, for example, they're in a domestic partnership, are not able to apply jointly for coverage. If you look at the application for the federal marketplace, it is actually possible for people to indicate that they are in a relationship with a same-sex partner that is not a marriage, and that is one of the biggest questions, I think, for the marketplaces as they're getting enrollment underway, is how is this working on the back end to keep those couples' records together, even if the initial application process tried to separate them. And finally, encouraging plans to offer benefits for same-sex couples on the same basis as spousal benefits for different sex couples. Not all insurers offer spousal coverage, but for those that do, this is an opportunity for the marketplaces in particular to exert leverage on the insurers and to say that if you are offering spousal coverage, then you must make that coverage available to people in a same-sex relationship as well. Next slide. So it feels ironic to say just the one challenge, since, as we know, the rollout of the marketplaces has been difficult. The process of implementing this very large and very complex law is full of challenges. But the one that I want to focus on right now is the specific challenge of connecting LGBT people with the options that the Affordable Care Act opens up for them with regard to insurance coverage. So again, looking at the new options through Medicaid, through the marketplaces, understanding the coverage that's available in light of the insurance market reforms, particularly non-discrimination, and figuring out how to make sure that LGBT people are aware of the benefits that they may be eligible for under the health reform law. Next slide. Next slide. In order to figure out how to do that, the Center for American Progress started a project in January of 2012 called the LGBT State Exchanges Project. That project works in 4 states specifically, California, Nevada, Colorado, and Maryland, to make sure that the architecture of the marketplaces as it was being built was able to appropriately serve LGBT people and their families. And one of the other activities that the LGBT State Exchanges Project has undertaken is a research project to look more closely at the experiences of LGBT individuals, particularly those in the income range that is eligible for subsidies, so folks making less than $45,000 a year. We conducted the research in May through August of this year. It involved 8 focus groups, 4 lesbian, gay, and bisexual individuals, all of whom did not have insurance coverage, and 4 groups with transgender individuals, all of whom had no insurance coverage. These focus groups took place in Philadelphia, Miami, Denver, and Los Angeles. And we were also able to field a national survey through knowledge networks of more than 860 LGBT people, both insured and uninsured, with incomes in that Medicaid and marketplace subsidy eligible range of under $45,000. Next slide. So this is one of the key findings of that research. I mentioned earlier that LGBT individuals experience uninsurance at rates higher than the general population, and this is indeed what we found looking at the experiences of LGBT people in this under $45,000 a year income bracket, finding that 34%, or more than 1 in 3 of these individuals, does not have insurance coverage. Looking at employer-sponsored coverage, very low, and if you look at the source of coverage for people who are insured, approximately 43% of people with insurance have coverage through their employer. That's much, much lower than the general population number of close to 60%. So seeing some really clear consequences here of the employment discrimination that many transgender, or that many LGBT people experience. Next slide. Some of the other basic findings with regard to the experiences of LGBT people, lower income LGBT folks, you see under 139% of the federal poverty level, 41% of the entire sample. If you look at comparable research done for the general population by Enroll America, we see that this is significantly higher than for the general population, in which 28% of the general population under $45,000 a year is in that lowest income bracket. So what we see here is a real disproportionate grouping of LGBT people in not just lower income brackets, up to 400% of poverty, but actually below 139%. The uninsured people in the sample, 2/3 of them had been without coverage for more than 2 years. And there's more information. We have a brief on our website, americanprogress.org, that delves into more, for those who are really into the numbers, that delves into some of the other statistics with regard to the experiences that LGBT people are having with regard to insurance coverage. Next slide. Looking at where uninsured LGBT people are living, unsurprisingly, unfortunately, almost half living in the southern states from Texas across to Florida and up toward Virginia and Maryland. That is, of course, many of the states that are actively resisting the implementation of the Affordable Care Act and the expansion of coverage available through Medicaid or through the marketplaces. So there's a significant concern looking especially at these states where we know large numbers of LGBT people live, many of whom have children, and many of whom are couples of color who are already experiencing multiple barriers to getting good health insurance coverage, to getting good health care, to getting jobs, etc. And so one of the major areas of focus for the work that we're doing is figuring out how to connect with LGBT people who are marginalized on the basis of a variety of factors operating in their lives. So looking, for example, at the experiences of couples of color with children in the South. Next slide. Just with regard to understanding a little bit more about what experiences LGBT people are having right now when they're trying to get coverage, 1 in 3 respondents in a same-sex relationship had tried to get partner coverage through an employer plan, and the vast majority of them found that process to be extremely difficult. Transgender focus group participants in particular reported the significant and constant discrimination from insurance companies, particularly in the form of those transgender exclusions that we talked about previously with regard to implementing the non-discrimination protections of the Affordable Care Act. Next slide. If you had to look for health insurance coverage, how would you feel? Unsurprisingly, we see many familiar words: worried, frustrated, overwhelmed, confused. Next slide. When we look at the focus group findings for transgender folks, I referenced earlier the theme of constant discrimination that people were experiencing. Healthcare for transgender people, as for anyone else, is a basic fundamental need. And for transgender people, it has the added aspect that many transgender people need access to specific healthcare services in order to live authentic lives. And overwhelmingly, transgender people reported not being able to get that healthcare that they needed. Insurance experiences, again, unsurprisingly, involve exclusions, and many reported healthcare experiences that were extremely negative, involving hostility and discrimination. There's, as a result, resulting reluctance to engage and a mistrust of the plan offerings and consumer assistance programs that are available under the Affordable Care Act. Next slide. Next slide. Some of the concerns that transgender focus group participants voiced when asked about what they feel their engagement with the marketplaces, for example, under the Affordable Care Act will be: I might be misgendered, experience discrimination and hostility, discussions of staff being incredulous about voice matching name, not being able or willing to answer questions, and asking inappropriate questions of people who are transgender. And you can see down there an attempt at making a little bit of light of a very heavy situation. I'm going to need to be in a good mood to take it. An expectation that they're not going to understand at all what I'm talking about. Next slide. And when asked specifically, what will you do if you face discrimination on the helpline, a Colorado participant summed it up: I will simply shut down. Next slide. Next slide. Some of the key findings from the LGB focus groups. In many cases, in many instances, the LGB focus groups were very similar to the general population in that skepticism is a major challenge. people are receiving many mixed messages about what the Affordable Care Act is and what they can expect from it, how it will affect them. So there is an overwhelming skepticism, again, unsurprisingly, among LGB people as well as among the general population. And for LGB individuals, many are used to thinking of insurance as individuals rather than as family coverage. If you all recall some of the discussions earlier about the degree to which it can be very difficult to get partner or family coverage for folks in same-sex relationships. Some of the specifics that the focus group respondents indicated would help them understand what the law may mean for them and make them feel that they are welcome and part of this process of health reform is some of these key indicators, such as pictures showing LGBT people, key terms, gender-neutral language, such as partner and in some cases spouse rather than husband or wife, and LGBT inclusive non-discrimination statements. And we can see a really excellent example of LGBT inclusive non-discrimination statements looking at the application again for the federal marketplace. Has the statement printed out for people to refer to, that I understand that under federal law, discrimination on the basis of, among other factors, sexual orientation or gender identity is not permitted, and inviting individuals to make complaints with the U.S. Department of Health and Human Services if they do experience discrimination. So that's a really key part of setting an expectation, apologies, setting an expectation that LGBT people are welcome here. Partnerships with LGBT community organizations and advertising in relevant media. And this is, again, for many of you who have been doing work around the health disparities affecting different populations, very similar to talking about strategies for reaching any group of people. Not assuming that the standard cookie cutter messaging is going to work for communities of color, for people in rural areas as opposed to an urban audience, and the same is true for LGBT individuals. Next slide. And this confirms, the research confirmed what the concern was with regard to the lack of awareness among LGBT people of the changes that the law makes. These numbers, again, are very similar to those for the general population, and it overwhelmingly reflects the last 3.5 years of confusion and noise, both in policy and political spaces and in the media, about what the Affordable Care Act is going to do. So overwhelmingly, LGBT respondents knew about the requirement that on January 1st, 2014, pretty much everybody has to have a minimum level of health insurance coverage, but overwhelmingly they did not know that there are actually provisions of the Affordable Care Act that will help make that coverage affordable and make it higher quality. Next slide. So that awareness gap is a major concern and a major aspect of the challenge that I referred to earlier of making sure that LGBT people are connected with their new coverage options. We have this population that has very high rates of uninsurance, this population that has experienced specific and systematic instances of discrimination on the basis of their sexual orientation or their gender identity. And again, all of us adrift in this sea of misinformation and confusion about the law. So figuring out how do we help LGBT people get over that hump of knowing about the law and expecting that they can access benefits through it. Looking at the key motivations that encouraged LGBT community members to investigate their options under the Affordable Care Act, very similar again to the general population, wanting to know if you or a family member gets sick, you won't have to worry about big medical bills or going into bankruptcy. Similarly, being able to find a plan that fits your budget and that the insurance plan you choose will be there to cover all of the care that you need. A significant number of LGBT respondents also said that the new LGBT inclusive non-discrimination protections that operate in the health insurance marketplaces in particular were a major reason that they would consider looking into options for coverage. Next slide. Next slide. So looking at once you've gotten folks to the point where they're considering whether they need to get insurance coverage and starting to think through their options, the most important facts that LGBT respondents wanted to hear with regard to selecting a plan is obviously first and foremost what plans cover. And that includes things such as for transgender people, again, what exclusions are operating in this plan that may keep me from getting the medically necessary health care that I need. Similarly, looking, for example, at the reproductive health options that are available through plans, particularly for people in same-sex relationships who want to start a family. Number two, that you cannot be denied coverage based on a pre-existing condition, financial help being available, and specifically for people in same-sex relationships, what are the rules around partner and family coverage? And this is what we've discussed earlier about the degree to which federal law governs whether people in a same-sex relationship can apply jointly for subsidies through the marketplaces, but figuring out what plans offer with regard to family coverage is a major consideration for LGBT people shopping around for coverage. And if you look down there at the happy Facebook thumbs up, a message with these 4 facts will reach 80% of an LGBT audience. So looking for ways of communicating with LGBT people about what's available for them under the Affordable Care Act, these 4 facts hit it on the nose for the vast majority of LGBT community members. Next slide. Looking at who LGBT people want to hear this information from, someone like you who has already gotten insurance from these new options, and pretty clear leader there. People also trusting healthcare providers and family members. If they were in a relationship, the top family member named was their partner, and if they were single, and this is again something very similar to the general population, is trusting moms. Also, we see some of the major players that are involved in the implementation of the law and the expansion of coverage, people from a state government agency such as the Department of Health, a health center, Medicaid offices, and federal government agencies. Slide. So looking at some of the best practices for facilities and for consumer assistance personnel that we distilled from the findings of this research included developing and displaying, again, the importance of setting the ground rules with non-discrimination policies that clearly and explicitly include sexual orientation and gender identity and expression, providing unisex bathrooms, some of these smaller indicators, but very important indicators that LGBT people are welcome here, such as safe space stickers or rainbow stickers, posters that show LGBT community members, things like LGBT magazines and newspapers available in waiting areas, and importantly, using surveys and evaluation forms that facilities are undertaking for purposes of improving cultural competency or assessing patient satisfaction, giving people the opportunity on those kinds of evaluations and forms to identify themselves as belonging to the LGBT population. And that is a frequently overlooked aspect of addressing LGBT healthcare disparities and health disparities generally, but one that is incredibly important, the question of data collection. Figuring out where we are, what experiences people are having, so that we can better assess how we go about getting to where we need to with regard to reducing the barriers that people are encountering and enhancing their ability to live safe and healthy lives. Next slide. Similarly, looking at the experiences of consumer assistance personnel in particular who have been doing work for many years with regard to enrollment in HIV/AIDS service programs, giving applicants the option to point or write down options themselves. Importantly, in particular for transgender people, documenting preferred pronoun and name in the file if it's different from the legal record. This is again something that may feel small for folks who have never had to fight to be recognized as the gender that they know they are. But for transgender people, this is an incredibly important aspect of making sure that transgender people feel welcome. And again, coming back to the idea of gender-neutral language, such as partner rather than husband or wife, and parent rather than mother or father. Next slide. And some of the questions that we know the consumer assistance personnel are going to get, and looking at some of the organizing actually that's been going on around the country to try to make sure that we're reaching LGBT community members. One of the most recent efforts is led by the Strong Families Initiative out in Oakland, and trying to compile these kinds of questions so that it's easier to make consumer assistance personnel aware of what are some of the questions that they need to be prepared, if not to have the answer immediately, to be figuring out what are the strategies for getting the information resources to answer questions such as finding the best plan if I am transgender, looking at what kind of family coverage is available, making sure that people living with conditions such as HIV are considering plans that are appropriate for their needs and that have the doctors that they may already have been seeing in network. And of course, coverage for children. Similarly, looking at services that are covered for transgender people, as well as anyone coming in with a specific condition or a specific healthcare need or concern, helping people walk through the plans to figure out which one may be best for them, and the question of how to make sure that high-quality insurance translates to high-quality care, helping people understand how to find LGBT competent physicians in the network of the plan that they're choosing. One of the most well-known ways of doing that is through the Gay and Lesbian Medical Association's provider directory, and there are increasing opportunities for providers to indicate through associations such as the HIV Medicine Association that they have experience working with LGBT community members. Next slide. So knowing that in many cases there are no simple answers for questions such as these, we have put together this initiative called Out2Enroll, which is again a partnership, actually next slide please, partnership between the Center for American Progress, the Stellars Dorsey Foundation, and the Federal Agencies Project, working with the White House and the Department of Health and Human Services. This initiative was launched in the White House event that I mentioned earlier on September 12th of this year, with the participation of Secretary Sebelius and other senior leaders from inside the government and out. The mission of Out2Enroll is to help LGBT community members connect with their new coverage options under the Affordable Care Act. And if you can go actually to the next slide, you can see the website that we have set up at out2enroll.org. And the next slide shows some of the questions with answers. For those who are wondering why I would put questions in a presentation and then not answer them. So there are many, of course, particularities for the experiences and needs of individual LGBT community members, but the Out2Enroll initiative is really an attempt to gather what we know about the frameworks within which the coverage expansion is rolling out. And the other aspect of Out2Enroll is we are doing a series of regional events where we talk with community members, community leaders in different parts of the country, particularly in those states where we know there are high numbers of people generally without insurance coverage, such as Texas, Florida, Ohio, and helping advocates working on the coverage expansion to understand where LGBT people are in the mix and how to make sure that their efforts are addressing the very real needs of LGBT people and their families. So with that, next slide is the last slide. And
Great.
Here are some of the resources that are available, and I'm happy to take questions.
Great. Thank you very much, Kellan, for a very informative presentation. And we've had a number of questions coming in, so I will go ahead and put some of those questions out there. And if you do have questions, you can keep typing them in. Or alternatively, if you do have your audio correctly activated, if you raise your hand, I can take your question that way as well. So, Kellan, I think you talked about this a little bit in the presentation, but our first question is, a person is interested in knowing more about proposed strategies to engage LGBTQ persons of color into coverage under the Affordable Care Act. So the person was wondering if you were aware of any strategies.
This is really the $50 million question, how to reach folks who are members of communities that are multiply disadvantaged and frequently overlooked in efforts such as the rollout of coverage under the Affordable Care Act. So I mentioned the effort by Strong Families, again, which is based in out of Oakland, doing a lot of organizing, particularly with groups that have been doing work around reproductive health and reproductive justice, seeing some of the intersections between LGBT work and reproductive justice, which has come very much out of the leadership of women of color, talking about the ways in which reproductive health advocacy needs to be broader than just looking, for example, at the issue of abortion access. So we've been seeing increasing efforts to organize at that intersection of reproductive justice and LGBTQ issues, and really utilizing the networks that have existed for talking about the healthcare needs that people have aside from coverage, to actually start talking about further upstream, how do we actually unlock the door to affordability for people? How do we get them coverage so that they're actually able to get services? So there's no easy answer to that question. I think for me, the emphasis, it really underscores the importance of thinking more deeply than just the canned messages that may have utility for moving the conversation forward on a national level, but really figuring out how to make sure that the materials people are seeing are representative of themselves and their communities, and again, utilizing some of those networks, particularly, again, reproductive justice organizing and Medicaid expansion as well.
Great. Thanks, Kellan. Now, I know you spoke a lot in the presentation about same-sex marriage and domestic partners, and so our next question is, how does the ACA impact married as well as domestic partners? So you already talked about this a little bit, but the person was also interested in the tax consequences, and then when they're using income determination, whose income is used? Is it that of the entire household, the partner, et cetera? So maybe we'll take those in turn. So the first part was the impact on married as well as domestic partners?
I think the main way that married couples are affected by the Affordable Care Act is actually to the further parts of the question about the tax consequences and about whose income is counted, what the household size actually is. The Affordable Care Act uses a new methodology, the Modified Adjusted Gross Income, MAGI, to determine eligibility for the tax credits and for Medicaid in expansion states. So MAGI is a little bit different from, for example, the existing rules around Medicaid eligibility in that it really depends on your federal tax filing. So whatever the income that you report on your federal taxes and whoever you claim as a dependent, or if you're in a same-sex marriage, reporting or filing jointly with your spouse, that determines the household size. But for most people, for people in same-sex relationships who are not legally married, it is very much an individual person-by-person determination of what subsidies people are eligible for on the basis of their own individual reported income. So there's no grouping of people into households for purposes of determining eligibility apart from their federal tax filing status.
Great. Thank you, Kellan.
One of the, yeah, and I actually because this is a frequent question, and MAGI is changing. Again, it is a pretty significant departure from the way some of these eligibility determination processes work now. The Center on Budget and Policy Priorities has actually been doing a series of webinars looking at calculation of subsidies and household size for purposes of the marketplace subsidies and Medicaid. So I would recommend them as a very good resource on this topic.
Great, thank you very much. So we have, the questions are coming in fast and furiously, so I'll try to get through as many of these as I can. So we have a question from Tim Gibbons, and the question is, with today's ACA changes announced by President Obama and the various insurance scams, what will drive consumers to trust in a medical provider who is surrounded by insurance policies that will only provide the minimum services? And his suggestion is, would it be better for Americans to seek care overseas with fixed prices and better practices?
I think that was a lot of questions in one. And there is a lot to think about with regard to the ways that the administration right now is trying to figure out how to minimize the impact of some of the changes required under the Affordable Care Act on different groups of people. I think the question of it all boils down to, is this going to work? And I am obviously no soothsayer, fortune teller, future seer, but when you look at the experiences of other efforts, other attempts at health system reform in the United States, the introduction of Medicare, Medicaid, Ryan White, Medicare Part D, everything was messy around the introduction and rollout of each of those initiatives. It took the last state, Arizona, 17 years to sign up for the initial Medicaid program after the program was started. Arizona didn't sign up until 1982. And figuring out how it's not possible at this point to say that things will be perfect and that everybody is going to have an easy time getting what they need. But this is a once-in-a-generation opportunity for the system to change and for people to be able to participate in making that happen. So it will be rocky. It is rocky already. But overall, I think the proof will be in the pudding when it comes to, over the next year, 2 years, 5 years, people getting coverage through the marketplaces being able to exert more pressure on insurance companies, regulators becoming more confident in figuring out how to enforce or apply the protections of the Affordable Care Act, and making sure that coverage is actually working. And to your last point, I'm not sure I would suggest going outside of the country. That is something actually that many transgender people do already, because it has been so difficult to find appropriate coverage options and to find appropriate healthcare providers. But I think ultimately the healthcare that we need is best gotten within the context of our own communities, and that in as much as we're doing more under the Affordable Care Act to build a better understanding of what has been referred to as a health care system rather than what we have more traditionally had, which is a sick care system, where you only get care if you're sick, and sometimes not even then. So I think the Affordable Care Act provides a pretty unprecedented opportunity to get more people involved in building a system that works better, and that a lot of that work isn't necessarily happening at the local level in our communities.
Great, thanks, Kellan. Our next question is from Allison Royce Sinclair, and the question is, how can transgender individuals be required to get health insurance under the ACA, since the majority of insurers under general exclusions do not cover sex transformation and anything leading up to that, such as therapy and hormone replacement therapy?
That's a big part of the work that we're doing with the LGBT State Exchanges Project and Out2Enroll, is recognizing that as people are being told that they need to get health insurance coverage, making sure that the products that they are buying are not defective, are not riddled with holes, are not riddled with exclusions, such as the ones that you referenced. So this is going back to what I was mentioning with the 5 jurisdictions that have now prohibited the use of transgender exclusions. I think that the Affordable Care Act is really driving that conversation about what does gender identity non-discrimination in insurance mean, because previously it wasn't really defined, and a lot of these exclusions have just been in plans for years because there's been no rationale with which we could compel insurers and regulators to look at these exclusions and say, this is not appropriate, this should not be in these plans. So it really is a state-by-state effort to help regulators have these conversations, to talk with insurers about what purpose the exclusions are supposed to serve, which if you push is really no purpose at all, and leveraging the non-discrimination tools in the Affordable Care Act to actually eliminate these exclusions over time. So that is, I think, where we're going, is this increasing understanding that these exclusions are actually discriminatory and illegal, but figuring out how to turn that recognition into reality is very much a state-by-state effort and a long-term effort. In the short term, there are plans that, sorry, I was just going to say in the short term there are plans that do not have transgender exclusions. Contrary to sort of what the insurance industry might have you believe, there are actually plans that are available for sale right now that do not have exclusions. So that's one of the important things for navigators and consumer assistance personnel to keep in mind when helping folks choose plans, because it's not just transgender people who are impacted by exclusions.
Excellent point. And so Allison, in follow-up to that question, was basically saying, in other words, why should someone be required to get coverage if it does not meet their needs? And I think you mentioned earlier in the presentation about trying to ensure that there is not a defective product that is being sold to the consumer.
And it just really underscores, again, the importance of the consumer assistance personnel in helping people understand what are the characteristics of the plans that they're looking at, and the importance of advocates working to ensure that it isn't simply a requirement that people buy insurance, quality be, quality be damned. It's all about this effort that I was referring to earlier of the Affordable Care Act opening up an opportunity for discussing why some of the ways that insurance is currently designed and sold, why some of those ways are problematic, and how we can take this opportunity to start making some changes.
Great. Thank you. And so this dovetails with the tail end of what you were mentioning about the 5 jurisdictions. So Carol Bull was wondering, can you describe some of the actions taken by the 5 jurisdictions you mentioned to reject trans insurance exclusions? And are there any other jurisdictions besides those 5 that are actually in the process of doing this as well? And if so, what are they?
In each of these 5 jurisdictions, the action that was taken was a bulletin from the insurance commissioner stating that the products that they regulate under state law are not allowed to have exclusions based on the insurance commissioner's interpretation of existing state law. And again, sort of in the context of the Affordable Care Act and some of these broader discussions that are starting to happen around non-discrimination. So we have a piece actually on the Center for American Progress website from May of this year looking at giving an overview of each of the 5 bulletins to date. And there is work underway in numerous other states. Again, this is about interpreting existing law. These protections on the basis of sex, for example, in some states protections on the basis of gender identity. This is really not new. It is simply a much more clear-cut understanding that gender identity non-discrimination in insurance really does have consequences, have an effect on the way that plans are designed and the way that coverage is administered. So I'm happy to talk offline with anybody about work that may be going on in various states.
Great. Thank you, Kellan. So this question from Bobby Daly is actually almost a case, it could be a nice case study. So I'm going to read the scenario to you, and I was wondering if you might be able to perhaps provide some insight. So the scenario is such: what if an LGBT, underemployed, and underinsured individual is being treated during 2013 for a catastrophic illness, such as a bone marrow transplant, which adds up to well over $1 million? If this person gets ACA coverage now, will that person be able to avoid declaring bankruptcy? So there are a couple of issues I see there, but I'll let you handle that, and then I might chime in after you're done.
Yeah, I mean, not being a broker or a lawyer, you know, please take my comments for what they're worth. With regard to somebody who's experiencing poor practices in the insurance market right now and is grappling with a very expensive illness, January 1, 2014 is a pretty key date, because that is the day when the coverage that is being sold through the marketplaces will come into effect. It's also the day when a lot of the insurance market reforms that I mentioned earlier come into effect. So the prohibition, for example, on the use of pre-existing condition exclusions. So under the Affordable Care Act, after January 1, 2014, there will be no medical underwriting allowed in these plans that are being sold through the marketplaces. So if this hypothetical individual is able to get into the marketplace, assess their options, purchase a plan, that plan, the cost of that plan, the premium, will not be affected by the fact of the existing condition, health condition that they're dealing with. So I would like to say, I mean, in as much as I see the facts laid out in the scenario and what's happening with the Affordable Care Act in 2014, yes, I think that person has excellent options for coverage that will actually be there. No annual caps, no lifetime caps, no pre-existing condition exclusions, no medical underwriting that makes the premiums more expensive. So that's, again, not being a specialist in this particular scenario. I think the Affordable Care Act does offer that person a lot. Sherry, did you have thoughts on that as well?
Yes, nope, actually you hit the specific items I was going to talk about. So that's perfect, yes, what you had mentioned, that as of January 1, the fact the person, because as of, if it weren't the ACA, that person wouldn't have been eligible in the first place because they had a pre-existing condition. They would have actually probably gone into bankruptcy because their insurance would have had a cap. So no, you covered everything adequately. Thank you so much. So we have a few more questions. We have a question from Audrey McDuff, who asks, do you foresee health insurance companies beginning to cover hormone therapy and surgery for trans people?
I do see that happening. Again, we've got the bulletins that have been happening in various jurisdictions where there's this growing understanding that plans are covering these kinds of services. Hormone therapy, for example, for transgender people is the exact same treatment that anyone with an endocrine disorder or postmenopausal women needs. And it's covered without question by most insurance plans for people who are not transgender. It's simply when you introduce being transgender into the conversation, all of a sudden it becomes, oh no, we don't cover that. And as I mentioned, the bulletins are trying to chip away at that status quo. The other place where change is really happening is actually in large self-insured plans. So those that are not actually affected by the Affordable Care Act because they are subject to ERISA. Many of these large plans as documented, or large employers as documented in the Corporate Equality Index from the Human Rights Campaign, 25% of the Fortune 500 is now offering plans that have to their employees that have no transgender exclusions and that do cover the services that transgender people need. So I think we see an interesting, some good examples being set by some of those large self-insured employers. And then we have, again, the application of the non-discrimination requirements and the insurance market reforms of the Affordable Care Act to say, you know, there are, just because these exclusions exist now does not mean that they are legal and does not mean that they will be allowed to stay as we as a country are making changes to what we expect from health insurance plans.
Great, thank you. And a couple more questions here. We have a question from Chucha Marquez, who asks, what protections exist for LGBT people seeking medical services who aren't covered by the ACA? So specifically, this would be undocumented LGBT folks.
That's a really excellent question, and it's many of the discussions that we've been able to have with available data do unfortunately focus on people who have citizenship documents from the United States. There is, of course, a very large population. I think the most recent estimate was 11 million undocumented people who will not, as you point out, be affected in many ways by the changes introduced under the Affordable Care Act. But one of the biggest changes that will actually have an effect for undocumented people generally and LGBT undocumented people specifically is the expansion of the services that are available through community health centers. So the Community Health Center program serves millions of people every year, and under the Affordable Care Act, the patient population is expected to at least double, and there is not enough money to ever. The community health centers should always get more support for the incredible work that they do. But the Affordable Care Act does put money towards the community health centers and is supporting many centers in opening new access points, remodeling facilities, hiring more staff. And so I think they're really going to continue to be key to how individuals who are still excluded from the health insurance system, such as undocumented people, will be able to continue to get care through community health centers. And again, not that any investment is sufficient, but the Affordable Care Act does invest in helping these community health centers cope with larger numbers of people seeking care.
Great. Thank you, Kellan. And so if there are any other questions, because we have about 2 minutes remaining, if you would feel free to please type those in now. And was there anyone who had a hand up who would like to ask their question verbally? Okay. I don't see any other hands, and I'm just going to take a quick look here and make sure I didn't miss any questions. Okay. I think Bobby Daly had a follow-up. This was the question about the case scenario, the hypothetical situation. So remember, that person was underemployed and underinsured, and so I think one of the issues here would be how would the person be able to pay the bills. Now, Bobby, are you talking about the bills for the actual premiums for the ACA coverage through the marketplace, or are you talking about the bills that would come from the actual medical services, which are two different things? Because I believe, Kellan, if the question is about the former, this might be getting into the whole issue of would the person be eligible under Medicaid expansion depending upon the state? Would they be eligible for some of the advanced tax credit benefits, et cetera? So I would just need clarification of that, Bobby, if you have a second.
Was there a clarification or?
Let's see. Nope, I did not see one come through. But as I said, if it was the former, Kellan, would you believe that it would have to deal with income eligibility that would determine what particular insurance the person would be eligible for? So public, either via Medicaid, depending on the state, if they did Medicaid expansion, versus the advanced tax credits.
Yes, that. I mean, that is sort of the first step that somebody would encounter when trying to think through what their insurance coverage options would be. And hopefully, there is a pretty serious concern with regard to people who make less than the federal poverty level living in states that have not expanded Medicaid, because those people are not eligible for subsidies to purchase coverage through the marketplaces. And because their state has not expanded Medicaid, they also have no options for Medicaid coverage. So that is, I think, one of the biggest areas of concern for many advocates, going back to the question of sort of what kind of organizing and strategies are happening with regard to implementing the Affordable Care Act for members of communities that are at particular disadvantage, either socially or economically. A lot of the groups that are working on health reform are really focusing on the need to make sure that all of the states expand their Medicaid programs.
I see. Well, I will wrap up with the clarification we received from Bobby, and I think I know how we might perhaps answer this, but the clarification is that the hypothetical person already has bills with bill collectors calling. So if these are indeed bills that were incurred here this year in 2013, once that person became eligible for coverage, would that coverage apply to those 2013 bills? And I know that neither one of us are navigators or assisters, and we're not, licensed in insurance, but it's my understanding that regarding if it's private insurance, there usually isn't a look back to retroactively cover previous bills you've incurred prior to the coverage date. Versus with Medicaid, depending on your state, sometimes there is. So while you're pending eligibility, if you are incurring bills during a certain time period, maybe 60 or 90 days, and it varies from state to state, then that might perhaps be covered. But again, I would highly suggest, Bobby, that in this hypothetical situation, or if you know someone who's in that situation, you might want to see, depending on what state you're in, going either to, again, healthcare.gov or seeing if it's a state marketplace or a federal-state partnership, and perhaps referring that person to a navigator or an assister in your area. In fact, Kellan, I just wanted to ask a quick poll here, a quick question, show of hands. If you had patients or if you yourself are seeking coverage, would you right now know where to go in your own state to seek assistance? Meaning, yes, there's a particular website, there's a toll-free number, but would you actually know where to refer people or yourself to get more information? By a show of hands. So a few, but not very many. And so, Kellan, this is one of the reasons, again, I think that we did this webinar. And our center also did 2 previous webinars. They were not focused specifically on the LGBTQ community, but it was looking at what healthcare providers need to know about the ACA so that, again, when their patients are asking questions, they can answer them, as well as what hospitals need to know about the ACA. So as we wrap up, I just wanted to remind you that we did record this webinar and that the presentation slides will be available on our center's website and as well as on, I'm sure, probably Kellan's websites as well. And the webinar recording will be on YouTube, on our center's YouTube channel. So I will be sending out an email letting you know exactly where to go to access these within 24 hours. But we really would hope that you would share this information widely with your colleagues, with those who are not able to participate in today's webinar. Because one thing we found is that there's a lot of misinformation out there about where to get information, what's available, and we want to try to connect as many people to coverage as possible. So I, again, strongly encourage you to please go to the links listed here, especially to the Out2Enroll.org website, as well as going to the AmericanProgress.org and these issue briefs that Kellan was referring to. Kellan, do you have any last few words that you'd like to leave us with?
I just want to thank you, Shuri, and again, everybody for joining us today. And please do feel free to visit our website at AmericanProgress.org and Out2Enroll.org and to follow up with me with any specific questions. So thank you all again. Great.
Thank you, Kellan. Thank you very much for an informative webinar. Thank you, everyone, for participating. Yes, go ahead. And thanks for participating, and please watch your inboxes to receive an email with further information. Have a great rest of the afternoon.